My 5 hacks for perfect and safe phaco. Tips from the masters in phaco emulsification. And it's basically a 3-minute presentation by each person regarding 5 important tips or hacks that they would like to share with the audience. And let us begin with Dr. Mahipal Sachdev. Needs no introduction, master in phaco emulsification and femtocataract surgery. So your timing will be 3 minutes, sir, to present 5 important tips in phaco.
Thank you very much, and I'll try to finish in 3 minutes, otherwise you can cut me short, whatever, because 5 tips in 3 minutes is slightly different. Thank you very much anyway, KSOS, for having invited me here. And the first tip that I am talking about is saving time for high volume surgeon, and that's a simultaneous incision, so you don't have to hold it separately. So what we do is that we hold the side port, that becomes the stabilizing hand, and then you use the main port, go in while the left hand is now stabilizing. So that's exactly, and once you have gone in, not fully, you pierce with the side port and then go in. So this is the first tip. Single throw 4-pass pupilloplasty in phakic eyes. Amar described it in a phakic eyes or pseudophakic eyes. But this is in case of a blunt trauma, the patient had traumatic mydriasis. So what we do simply in this particular tip is that we put in a lens, a plate haptic lens, and then go ahead, because you need a support, otherwise with this long needle you can go and puncture the anterior capsule of the lens. So you go ahead in this particular case and you will complete the SFT. In this case, as you can see, we are able to do this pretty well. And once before tying the suture, but we have already got the sutures entangled, we remove the lens and then go ahead and do the pupilloplasty, the completion of the pupilloplasty. So this is my second tip for you. And then if there is a small pupil for people who do a femto, this is our own BX ring. So you can use a BX ring, as you can see in this particular case. So this is again a tip that a femto is not contraindicated absolutely in case of small people. So you can see here, this is the BX ring in position. You have done a capsulotomy and you have done a nucleotomy, and then you have removed the BX ring. This is a technique of patients who have an iris prolapse in, subluxation of the lens, and you see a vitreous here. In this particular case, we have described limited pars plana vitrectomy. Thanks, I have 1 minute more, yeah. So you can see in this particular case, what we do is that we can have the pupil centered. In this case, what I'm showing here is that we have gone in from the pars plana, and we have done a femto before that. What is important here is that you are decompressing the vitreous. That is something important, that you use the third hand, as I call it. And once you are using that, you are able to and put a CTR in this particular case and really remove the nucleus and the cortex, etc. But this is always there, the third hand to any, so you are not over hydrating or over filtering, over infusing the vitreous and causing more and excessive vitreous loss. So this is again the last one, that when you are using having a posterior polar cataract, the imaging helps you see in a femto laser. So you can see this is a pre-existing defect which is very clear. This is a polar cataract. So what we will do in this particular case is to do a femto. You can see here, this is a big defect which is there. So the OCT is the guide for you in the, so this is a pearl that I would wish to say, that in any posterior polar cataract, you can see this is an intra-op OCT. We have done a good capsulotomy, we have done a nucleotomy, so we can remove it. So there is no loss of vitreous. You can still see that in the intra-op OCT that there is a dehiscence which is there, and it is only at the extreme end because you have raised the default, and it is here also that the vitreous is herniating. So the key here was that when you have the OCT image which is available to you, you just raise the OCT image so that the default which you have is not the nucleotomy, is of giving you a great epinuclear cushion. So this is the key, that you are raising it, and this is the tip so that you can get a good nucleotomy which is there. So these are my 5 tips for various things that we have in the femto and the phaco to make things easier for you. Thank you very much for your kind attention. Thank you.
Thank you so much, sir. I request Dr. T.P. Lahane to come forward. Sir, one question to you. Where the case where you put B hex and then took the patient for femto, the AC is formed with?
So if you can leave the viscoelastic, you just increase the energy settings. If you want to aspirate it, then put a suture.
Okay.
If the viscoelastic is removed, you fill it with the BSS or whatever.
And put a suture and send for femto.
Then, under aseptic conditions. Okay. If you leave the viscoelastic, there is no need for that, but that again has to be under aseptic conditions.
And we are using the Zimmer now. So that is used in the same room, and so we are not shifting. So we can use it in the same room with a sterile head and everything sterile also.
You are absolutely right. So it depends on, there are a lot of people who have the femto and the phaco in the same room, so that can be done. But all that I am trying to say is that a small pupil can be managed with the femto.
Thank you so much, sir. Lahane, sir.
Thank you very much, all the chairpersons. And now this is my 4 hacks in the check your phaco machine and parameter before surgery. Whenever I do that, I check it before surgery. See here, you can see the phaco tip, it is broken. So whenever you are going, so complications happens because you have not seen your machine when you have started, or the sleeve is leaking. So I always feel that whenever you are choosing the patient, choose it widely. Now see, this is the patient where the PC tear has happened. So whenever you are choosing the patient, I think you must thoroughly investigate the patient. And once you thoroughly investigate, even the slit lamp, and you can go for the OCT, or you can go for, in such mature cataract cases, for the sonography also. So then that will help you. So here you can see the this IOL scaffold I am doing, and then I am removing. So whenever there is a problem, in that you must keep silence for few minutes, and after that you think what is to be done. So that don't do anything by haste. If you are not doing it, then another thing is ego. See, whenever you are doing phaco, all phaco surgeons, including me, are egoistic. So that ego you will have to, you can say, burn, and go to the SICS when there is a one piece remaining. And that one piece will help you, give you peace of mind, and second day, your, you can say, the pulse rate is normal, the patient's, everything is normal. Now, stick to the basic technology. What happens now, there are so many technologies are coming, and what happens now, we always think for the new technologies, and then basic technology we forget. It is whenever you are going, you go for the stop and chop technique when there is a, you can say, such type of nuclear cataract. Now here, we chop, chop and chop, but once you chop in such situation, the chop will not be complete, and you can chop you can some iris or PC. Now see what happens, fast can be furious. So if you are doing everything fast, what happens, phaco is not fast surgery. But if you are doing everything fast, so that fast will not help you. So I always say that whatever the surgery is there, you must take your own time. And this is very, very important, that whenever you are doing any surgery, so go slow. And once you go slow, then there should not be any problem. But if you are fast, then what happens, when you have done what, you will not understand, and then there will be a problem. So I always feel that, so whenever you are doing anything, you should go slow, and once you go slow, then there is no problem. Thank you. And I always use AC maintainer in my all cases. Thank you very much.
As Dr. J.K. Reddy gets ready, sir, comment by Dr. Matthew.
So, actually, especially for an initial beginner, using this HC maintainer trick will be a good learning point, because foot pedal control, accidentally they tend to come into no irrigation, and then that causes a problem. Thank you very much, Professor Lahane.
J.K., please.
Yeah, good afternoon, and this is number one. See, this is the beginning and end of the creation. So the beginning of end of the cataract surgery is incision. That's the first step and the last step. So my advice is no touch technique. Don't touch. The patient will get it. You put some forceps or bud, they get confused. So don't need. You just need two instruments, as I shown you in the video. You just do it with the two, just support with the side port and make with the main port. This we are practicing, all the surgeons in our hospital doing it. It's very easy. It's a very easy technique. Then in the end, the incision should be good enough to comfortably go for the whatever lens you are using, whatever cartridge. Don't put side instruments since spatula. I saw one video where they're putting even forceps inside the side port. No, this is ridiculous. Just don't touch. You have to just cartridge should go comfortably and go. That's the about the second hack is when you're doing, all we are taught is horizontal phaco. That is taught 10, 20 years back. 20 years is a long time. You don't need a horizontal phaco. You have to do you don't need a vertical trench. You need a horizontal trench in phaco. If it's a heart, you just don't go beyond the center of the nucleus. Just do a horizontal trench, then hold it and chop it. That is my two hack. This one which is very, very, very useful to crack the even hardest nucleus. The third one is cortex. So everything goes when most of the PC rents happens in the cortex. That's what I got statistical analysis where the PC rent happens. So just before the handpiece changes, it takes 20 seconds, 15 to 20 seconds depending upon the staff nurse. During that time, do a second hydrodissection of the central cortex, and just one sweep, you can just remove all the cortex. Okay, you don't need anything else. And the fourth one is the trailing haptic caught in the cartridge. Just take your McPherson, pull it off. It will come. Don't do that. I saw in ECRS, they messed it up. That's why I'm showing this. In ECRS, I saw they are doing so many tricks. They have shown nothing works. Just pull it off in hydrophilic. And the same thing. It's a very repeatable technique. You got the trailing haptic caught in the cartridge. Take a forceps and just pull it off. That will come. Okay. The fifth one is the antibiotic prophylaxis intracameral. That's a bit, still, I am using it, but not the world. Mixing in the BSS 0.1 ml of amikacin, 500 ml of BSS, that is 12.5 milligrams. That solves all the problem. That's much, much better. Moxifloxacin use reduces the endophthalmitis rate by 1:5. But we, in our 2 lakh cases, we found that amikacin add in the BSS prevents almost 15 times. The endophthalmitis rates comes down 15 times. Thank you very much for your patient listening.
Sir, this is regarding the first video. You have shown paracentesis knife in your left hand and main incision knife, keratome in your right hand. Suppose it is the right eye, suddenly patient is getting a Bell's movement. How you tackle?
See, the complications, when any surgery will happen, complications known to happen. So I had, in my entire 15 years I am practicing this, I had 2 times this complication. So I changed, the incision became too big, then I took another site and did it. It's happened. It's rare, very rare, don't worry.
MVR, nowadays I am using MVR. So MVR, once it goes in, the blunt tip remains in the paracentesis.
I never used MVR, so I know experience.
I'm just telling, as I was also using the 15 blade only. Now, because the MVR is being, the sharp end goes into the AC, and the blunt one remains inside the paracentesis, and even if patient moves, nothing happens to the paracentesis.
Yeah,
The same version is available with the Oralab side ports, which are also very cheap, not as costly as the MVR. So basically, the initial triangular portion edges are sharp and cutting, but the rest of the shaft is blunt on both sides. So even if there is bells, there is no extension of the wound.
Ultimately my point is correct.
And regarding amikacin,
don't touch the eye.
This has been published.
Huh?
The results of amikacin and BSS has been published.
Many times. It's a very, 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 very powerful and very effective, no problem.
Thank you, Dr. JK. The next presenter is Anand. Please note, next presenter is Dr. Sudeep Das. Sudeep Das. Dr. Mallikarjun is in another presentation. So please get Dr. Sudeep's presentation.
Yeah, thank you for this. So this is not a hack, but this is posture which I want everyone to notice, because I keep telling my juniors I've been operating for 30 years without spondylitis. Then the other thing is I use just 3 fingers for holding. And if you saw, basically all my movements are rotatory. So here also I use the right hand only. So all I did is sort of pronate from supinate, pronate, and then enter. And if you see the forceps to everything else I'm using with, so my movements are very, very less. And the same thing I use, whether it's a chopper, I'm again using 3 fingers. If you see from outside, all you'll see is just a rotatory movement. My hand is hardly, you won't see my fingers really moving much. Then this is the other thing. So basically, I'm flipping the needle, capsulotomy needle completely. If you see, it's sort of hanging down like a bell clapper, and then it just rotates sideways and enters. So if you see, it's like this. So I'm not moving it sideways. The profile is much thinner in this way. So this is what it will look like in a video. So if you see, it's just like this. It just slides in. All I'm doing is turning like bell clapper, and it's inside. And the other thing, if you'll notice, is because I'm using these 3 fingers, again, there's hardly any movement. You will see the capsulotomy happening. This is real time, but from outside, you'll hardly see anything. My fingers are just sort of rotating. That's all. The other thing is holding I'll always hold the cannula. I'll never hold the syringe with 1 finger on the cannula. So whether it's the trypan blue, whether it's viscoelastic, anything. So if it slips, I'll have a whole lot of viscoelastic in my finger. There's absolutely no chance that the cannula will ever slip and go into the eye and do some damage. And all I have to do is I can rotate it. I can face whichever way, any clock hour, I can do anything. Then safe chopping. This is basically, if you see, I'm rotating it not sideways, it's rotating in the arc. The nucleus is always rotating in the arc of the capsule. I'm not ever pushing it sideways, where you're sort of flattening the equator. And then it goes back again. So every time it's sort of moving along the arc of the capsule and then going back. So basically a 3-finger grip for delicate control of everything, twirling movement while capsulorhexis, chopping, IA, anything. And bell clapper movement for entering the anterior chamber through the side ports. Hold the cannula directly and move the chopper in the arc of the lens equator. And sit properly in the OT. Otherwise, you'll not operate for very long. Thank you.
We'll have a few questions for Dr. Sudeep. Meanwhile, Dr. Mallikarjun, can you please come? Anand, next presentation, Mallikarjun.
So you're using your little finger and ring finger to stabilize your hand?
Yes, and these are sort of moving. Yeah.
That's it.
Good afternoon, everyone, and thank Dr. Srini for this opportunity and KSOS. And I think earlier speakers and all, they have talked more of phaco surgery, but I'll talk something surrounding the phaco surgery, what you have to do. So the most common cause for endophthalmitis is the poor hygiene of leads. So if the eyelashes come in between the surgical field, that is one of the most common causes for endophthalmitis. I use this lid glide, which is developed by us in our institute, and this should help us to retract the eyelid, and the eyelashes will be pushed away, and we can make a good draping of the eye, and the surface ocular field will become eyelashes free. This is very important for the beginners to insert the 3-piece IOL. Instead of putting the IOL from the above, you have to slide it inside the cartridge, and push the plunger. Once the plunger is touched the eyeball, you have to lift it up so that it won't touch the optic haptic junction. Because most common problem here is the breakage of the at optic haptic junction. And you put the insert the eyeball, making the bevel down, and this is actually sensor eyeball. And once half of the eyeball comes out, you rotate the cartridge anti-clockwise. And with the tip of plunger, you can rotate the eyeball and put it directly into the bag. And this is a very common issue we have, especially when you do a soft cataract. These are all the fibers. Don't try to do it with a eye probe or use a polisher. I just do a hydro PC polishing. You jet of a fluid, you can just wash away all the fluids, and you can make the PC very clear. And all the fear and complications of using an eye probe and the PC polisher will not be there. And this is one recently I've been doing it for hypermature Morgan cataract. For first you make a rhexis and lift the Morgan cataract up and place the IOL in the back first, then do a phacoemulsification. It is very safe. The IOL will not, the lens will not move anywhere, and it sits on the IOL, and you can do a nice phacoemulsification without fear of making PC tear or general dialysis. This is the one hydroimplantation cannula which we have developed in our center. This is especially useful for coaxial surgeons, those who have coaxial eye probe, because advantage of hydroimplantation in the toric IOL is there is no visco at all here. So you put an IOL in the bag and just align the IOL at the axis and take out the probe. That's all. There is no need to manipulation at all. And chances of rotations are very less. Thank you. I finished in less than 3 minutes.
Which company makes this lid retractor? Where do you buy this lid retractor company? The lid which you used?
Yes, now it is commercially available, and 2-3 companies are making it now.
Which one, please? Let everybody know, no. It's an important thing to have.
One is Appasamy is making it, and one is Cardiocare.
No financial interest, but then let people know that Appasamy has it.
Appasamy and Cardiocare, they are making it. And they have named it after my name, because I never asked them, because they have named it after my name.
Second company, what is the name you said?
Cardiocare. Cardiocare.
Oh, okay.
That one more cannula, it is going to come into the market later. That hydroimplantation cannula, only that is very useful for those who do a coaxial cortex aspiration. Those are not used to their bimanual thing, because bimanual, who does the bimanual cortex aspiration, it's very easy for them to do a hydroimplantation. And also this can be used in SICS also.
Thank you very much, Dr. Mallikarjun. Ramurthy sir has come. Yeah, we'll do madams first. I invite Dr. Chitra Ramurthy for her presentation.
There's an audio in it also. Huh? Okay. Very good afternoon to one and all of you. These are very simple tips which I'm going to show, and but which is definitely relevant and something which you already most of us know about. So there it all starts. So setting the process in motion, like if a patient comes to you at the reception desk, says he wants a cataract surgery, it makes sense to take the patient, the optometrist takes the patient and does an optical biometry right away, so that the tear film is intact and there's absolutely nothing which can go wrong or the standard deviations going wrong. And once you know the person has toricity, you can guide your discussion in a different manner. Again, it's very, very important that if you use a 2.4 millimeter incision at all times, the centroid value is less than 0.1, it doesn't matter, and you can even insert the lens without wound enlargement or any kind of a wound distortion. So probably the ideal number is 2.4 unless the particular IOL demands a larger incision. And of course, removing the viscoelastic from behind and everything is to be done. The nucleus management in a soft cataract, especially if it is a prelex, there are very simple ways of dealing with it. Just a gentle hydro, and you find that though the rexis is normal size, you have the entire soft nucleus coming forward, and you can just carousel it out if you keep it on the flip mode on the phaco machine, and then it's all about aspiration. If you're on the femtocataract platform, you could make sextants without softening. So you would have a free floating rexis invariably. So, and then you could do an inside out hydrodelineation along the different incisions in some of the axes where it is, you are able to approach it. And then after just gently removing the superficial cortex and epinucleus, you can see that it looks as if each of these spaces are waiting to be gobbled, and then you can just remove them. And then it's just a child's play. You have to just do a cortical wash, a PC polish, and then it's done. If the rexis centration in a colobomatosis eye is another very important thing to keep in mind. It makes sense because you could end up, because of the asymmetric pupil, you could end up with an asymmetric rexis. So if you ensure that you use an iris hook in all of these cases, it sorts of rounds it off, and you ensure that you start your rexis not too close in that area of iris coloboma, a little away, but still ensure that it is centered and it's a little away from that particular area. And then it is of course often an hard cataract, and you could chop it the usual way. And then you see when you insert the lens, it is well centered, and that's one trick which we need to adopt. Last but not the least is a PC plaque, which could come up in a silicone oil injection. So after doing the cataract, ensuring that there has been no lens touch in these eyes, you find there's a plaque here. So you could actually, if you find a plane of cleavage, all that you need to do is just peel it off and it gets done. But otherwise, if the posterior plaque is resistant, it's better to wait and YAG it later. Thank you very much.
One quick question. When you do the hydrodissection through the sextants, would you release
hydrodelineation?
Would you release the air bubbles first and then inject?
Yes, of course. If you see obvious air bubbles, then you would do a hydrodelineation. You can decompress and again do the next hydrodelineation. You won't keep on doing hydrodelineation without doing a decompression alternately. Thank you.
I think it's more suitable for a soft cataract and not a very hard cataract where there is a lot of air bubble inside.
Yes.
It would be better to just release the air bubbles and then go ahead.
Yes. Thank you.
Any other questions or comments for Madam? Thank you, ma'am. I request Dr. Amurthy sir to please come forward with his presentation. Anand.
At the outset, I would like to thank the organizing committee of this wonderful meeting and this session, to chairpersons to have given me this chance. Let me, in 3 minutes, 5 topics, let's try to finish it. Morganglian cataract like this, you'd find that one of the safety measures that I employ sometimes is IOL scaffold. You know that these cataracts can often be associated with a tremulous capsular bag. There is a tendency for the capsule to trampoline forwards. So in these cases, I'm sorry about that. That's the liquefied cortical material which is flowing out, and the capsular rexis is not really a challenge in these situations because I think let's. It was running fine. If you want, we can skip this video and. Huh? Okay. Yeah. So as you can see here, that's the lens material which flowed out, and it's a nucleus which is hard as a nut but quite small, but obviously this will spin around, and there's always a tendency for the capsular bag to move forward. So what I do is before doing the phaco emulsification, I go ahead and implant the lens, as in this case a single piece hydrophobic acrylic lens. Obviously this can be quite challenging for the corneal endothelium. But as you can see, it's a brittle cataract, and with a significant amount of dispersive viscoelastic, we go ahead and remove the lens, and then that intraocular lens acting as a safety measure as far as this case is concerned. Next. It's not working here. And hydroimplantation, many of you might be already doing it. It's a good idea to have an irrigation cannula all the way inside, and as you can see here, that acts as guides the lens into the capsular bag directly. It's a 2.4 or a 2.8 millimeter incision, depending upon the kind of intraocular lens that you are implanting. It's a toric implant. I have the Varion overlay on, and you would see it right in the end. And you are able to position this. Initially, I kept the IOPs 90 just to bloat up the capsular bag, but then I bring it down to my normal 30, and that's the intraocular lens which has been placed. There's no, especially with toric intraocular lenses, it's an advantage because there is no viscoelastic that needs to be evacuated. That shows the positioning of the lens. Next. This is something that I do routinely. After removal of the nucleus, it's just a stream of fluid, BSS, that is polished onto the posterior capsule. Whatever small tags, fibers that are there are completely taken off. This gives you a great impression of clarity right on the operating table, and also on post-operative day 1. It's nice to see these eyes on the slit lamp with a crystal clear posterior capsule. Of course, if it's a fibrotic patch or something, that's not going to come away. But any fibers or any small pigments on the posterior capsule, it's easily washed away. Next. And can you just switch on to? There are several patients who have had a monofocal implant earlier and now want independent some glasses. And especially if the patient has received a multifocal implant in the second eye and now wants the first eye something to be done, which was operated years back. This is a diffractive trifocal lens which is available from an Indian manufacturer, no financial interest. And I don't use it very often, but this is a choice. And you can implant it. It's a hydrophilic acrylic lens. It comes with a 1.75 and a 3.5 diopter add. And this seems to take care of the intermediate and visual needs of the patients. Next. And finally, as far as the toricity is concerned, very often I am asked, what is the power beyond which you suggest a toric lens? But then what you must understand is that it's not just the power alone. Axis itself is extremely important. When you are using something like a, can I use this? No, the previous slide. Okay, thanks. When you use something like this, a 0.60 against the rule astigmatism, and you find that what the Barrett toric calculator is recommending almost a 1.5 T5 lens to be implanted, T3 lens to be implanted, it's little more astigmatism than that, a 0.68 astigmatism, just because it's oblique astigmatism, there's no, it's a non-toric that's needed. So it's not just the cylinder alone, quantity alone that's determining this, but also the axis of the cylinder is extremely important. So our go-to formula today is not Barrett Universal 2, but Barrett toric calculator. Every patient gets examined in that, and depending upon what the cylinder is suggested, you can go with it. And it is not just in case you don't have an optical biometer, you can go to the ASCRS or the APASCRS websites. Right on the home page, you have this drop-down menu. You can use the same formula, and what I am trying to drive home, you can see that a 0.75 diopters 180 against the rule astigmatism, the lens that is needed is a T3. The same amount of astigmatism, 0.75 at 90, the lens that's recommended is non-toric. So it's not just the dimension of the astigmatism, but the axis also that matters. Thank you so much.
Thank you, sir. See, the IOL scaffold is actually more protective to the endothelium. See, you have these sort of cataracts with milky cortex and all. Even the posterior capsule will be a bit floppy. Yeah. So if you're doing without the scaffold, you have a tendency actually to come more up. With the IOL there, you can safely go more posterior. So for me, with an IOL scaffold there, it is actually more protective rather than more damaging to the endothelium.
And usually I give a dispersive viscoelastic,
Yeah, that's,
and then feed in some
yeah, so
HPLC, and
actually,
in that
obviously
lake we do
we'll
that.
be using, but the position of your phaco tip, I'm telling.
You're more confident.
Yeah, you're more confident to go more posteriorly because it's definitely not going to catch the PC through the sides of the that small nucleus that is there. This was a bigger one. You have very small nuclei coming in there. Definitely the scaffold will be much better. You know?
Yeah, the thing is, many smaller or moderate nuclei, I push it back into the back. And on sometimes some I only tilt and get the IOL inside, and the phaco happens in the bag itself. So if it comes on top, as you said, there is much more space actually, rather than what we think. But still in the AC, I do not split so widely, you know, and I don't do the regular kind of complete chopping. I do partial choppings and put in viscoat intermittently and then do it slightly slowly so that...
I'll add to that. See, phacoing on top of this IOL is a funny feeling. Like it keeps slipping. So what I do is eat a portion of it, then you hold it. Then you can chop easily. One portion you eat, hold it there, then you chop. It works wonderfully well. Anything?
Sir, regarding your comment on toric lenses, which is the calculator that you always use the toric, the Barrett toric?
Yeah, you know, we were using
and you
the
go
Barrett
according to the recommendation of that itself. You don't make any changes or...
No, what I'm trying to say is when the patient walks in with the cataract, first time he is made to sit on the optical biometer, we use the Barrett toric calculator. Earlier we were using universal 2, then the patient will say just a 0.7 diopter, counsel the patient for multifocal, etc. Then you find that the patient needs a toric lens, and then the entire counseling changes. Now with this, if we find T2 we ignore, but if it is T3 or anything more, especially if it's a multifocal lens, the entire counseling is for a toric multifocal or a toric monofocal, and if it's less than that, it's a we find it works very well.
Suppose you've already had a multifocal in one eye. Second eye, you find that the astigmatism is slightly more. Do you go in for a toric multifocal, or till what level would you go in for a normal multifocal?
No, as I said, I don't go by level at all. I mean, not the number of the cylinder, but what does the calculator tell me? If it's sometimes highly demanding patients, cost is not a criteria, trifocal lens you are implanting, I go ahead and implant a toric trifocal even for a T2. T3 onwards, whether it's a monofocal or a trifocal, we tell the patients you'll be missing something if you don't go for a toric. And that seems to, and second eye, there are so many cases, you know, we're not so concerned about toricity earlier. And some patients who have been done by us itself 3-5 years later, now come back with us for the second eye. We tell them this is a better lens, and many of them accept it.
Yeah, I think toric if it is multifocal, if there is some, even the T2 or the smallest one it is showing, I'll better take a toric multifocal than this one, because otherwise mostly they are very happy with the other eye. Then a slight thing also they will say this is always a little smaller. So I don't avoid the toric lenses.
I think residual toricity is one of the most important causes for an unhappy multifocal patient. Absolutely. Thank you so much, sir. Dr. Krishna Prasad.
So thank you very much for having me here. So I know I'll be coming late, and most of it are probably I'm exhausted all the hacks. So I'm coming out with a very simple hack. Basically, last 2 years I have been only doing hydro delineation in all my cases, so that only hydro dissection, no hydro delineation. And also I rotate it, not like netto rosately, but I'm rotating things little more and more, elaborately than otherwise normally I would do, which probably has reduced my, cortex aspiration time greatly. And also by not having an epinucleus with all its attendance problems, I think having just a bulky single nucleus without a epinucleus would be definitely a great game changer. And the second thing is my use of sharp chopper has increased tremendously in the last 2 years. I was doing stop and chop for most of the softer cataracts, and little dense cataracts also, unless it was a very hard cataract. But now I have found we can, with an experience, we can actually, and using the same chopper all the time, you can actually try to chop most of the cases, unless it is very soft. And this sharp chopper will definitely be more zonule friendly, and also it will definitely fragment the nucleus much faster than you trying to make a trench, divide them and create all the zonal stress. So this has been my learning last 2 years, and it has really benefited me greatly. And the other two is not, the other three are not related to basically surgical steps. One is about use of medication. After a lot of deliberation and getting influences from others, now my steroids are only 4 times for 1 week, and Nepavans or Nepafenac is once for 4 weeks. In most of my cases, which are straightforward, uneventful cases and the things they follow. So this has greatly reduced the inconvenience and the quality of life for the patients, where they have a lot of problems putting the drops. And of late, I have not found much of a patient coming with any flare-up of reaction or any other problems. And this has really worked for most. If there's a problem, uneventful case, or requires a lot of post-op medication, then I'll change this accordingly. And this is SAVE. SAVE is acronym for self-assessment of vision every day. This chart we prepared for some other program, and now I've been handing this chart. It is used for, there is an instruction at the back, how to use this at 4 meters, and the patient from day 2 is taught by the counselors how to use the chart. It is like a standard chart at 4 meters, you keep reading it, and if the patient has a drop in the vision, most of the topical phacos will see well, despite the minor refractive errors. If there is a drop in the vision, then the patient can keep on assessing. So we give it to patients, especially who are far off, so they can really know when to actually come back, and this has really worked a lot in some cases. And the last one is about, in select cases where I'm doing monovision, I can always call them for a glass prescription 1 or 2 weeks, but I prescribe a +2 right on day 1 of my second eye of the surgery, so that I have found that because patients can't wait to see clearly for 1 or 2 weeks, even that is actually difficult, or so this can be a definite plus point if you just give a plus reader, which is very simple, very economical, and giving them a glasses right from day 1 on the second eye, they can actually be very happy from day 1 to read or look into their mobile, and there will be actually an enhancement of their patient satisfaction. Thank you very much. Save? You're saving yourself from...
Save, I mean, I didn't get the idea of...
Save is, this was a chart, I mean, we have basically, reduced the number, made our own chart, which is to be used for...
No, why did you start thinking about something like that?
It started like, see, basically, you are ophthalmologist. The only thing, most of the problems come out with the patient basically manifests or comes up with a vision loss. And this vision, estimation need not be done by an optometrist or ophthalmologist. It can, anybody with a chart can do it. It is like giving the patient and empowering the public to check their own vision.
No,
if there's a problem...
This is not post-op.
Not post-op, no.
Post-op.
Post-op.
Immediate post-op.
Immediate post-op to check. It is not 6'6". This is a chart which is modified to be used at 10 feet.
You give 6'12", they'll be happy reading last line.
No, this is not a 6'6" vision chart. It is to be used at 10 feet. It is basically for comparison. It is not for absolute measurement. From today what you saw, from tomorrow it should be the same or it should get better. It should not drop. So the instructions are very clear. We are saying if you don't read the last line, it's okay.
I'm not convinced. I'm not. See, you go to the Ayurveda people, they actually say, okay, with the Ayurveda treatment, vision has improved. They keep taking the patient.
No.
So why should?
No. I will explain the rationale. There are a lot of postgraduates here. See, whenever you introduce microorganisms into the eye, till they get into the vitreous, there is no drop in the vision. Vitreous involvement by microorganisms is the turning point, which will drastically reduce the vision. Okay, that can happen on say, day 2, day 3, day 4, never know. So when the patient, most of our cataract post-op, you can see that they get good vision to at least see 10 feet. It is not that they have to read the whole chart. They are seeing the 2 lines at 10 feet on day 1. Second day it should be same, if not better. But if it drops, they're not able to see the chart. So this is an objective way. You can just say, see, drop in the vision without any actual measurement It's a very, very qualitative. Patient, old people may not really know. And there may not be anybody can have. Vision is, whether they're seeing or not, is a very qualitative thing. This is a semi-quantitative thing, which actually has worked. We have been using it for the last 10 years.
I've been taught well.
And it has actually saved us from people that are reporting early. Our post-op patients with the problems have been reporting early because of this.
Like we said, in Malayalam here, idoru kodali avu ennoru samshayam undennu.
Kodali means, okay.
Anyway, the thing is, no. I think this axe is very, very blunt.
Sir, again about the post-op medication. 1 week antibiotic steroid combination. 1 week.
1 week.
4 times a day for 1 week. And then
stop.
And then 1 month, once a day.
Nepafenac. So this was little revolutionary, but we kind of started pilots and we have found, and this is not for 100% of patients. This goes to around 80% of my patients, and it has worked well. And it has drastically reduced the ocular surface problems, obviously, and the patient's quality of life.
So this 80% you choose or
I choose.
You choose.
I choose. I choose the patients.
Then patients don't have a problem. See, there are patients who are sitting together.
Patients who are very bad diabetics, where there is a tissue handling, or there is some kind of, we use iris hooks. So basically where there has been a tissue handling, it is not a very quick surgery, not a quick surgery, then obviously you need to step up the steroid a little more. We have a different, but it's not for 4 weeks of steroids. We quickly taper it in 2-3 weeks only. But Nepafenac, we try to use it twice. Rather than
one problem we face is that a few patients come and sit close to each other, when post-op third day and all those. They will keep talking and they will say, I have been given drop only for 1 week. You are for how many weeks? I am for 1 month. 1 month. Why should you use 1 month? Then it is something is wrong. I have been told wrong. You had same surgery? You had, then it is trouble explaining to them is what I have realized. And that is a practical problem which we face in our clinic.
Yeah, maybe that's something that can happen, yes. So maybe our post-ops patient don't sit together. Thank you very much.
So thank you. Any more comments, questions?
Jason?
This is again regarding post-op medicines. Can you explain to us again what are the advantage that you...
So this is something which I have consciously been doing after a lot of deliberations. This really took 10 years to come to this conclusion. Because we have a group, WhatsApp group called phaco Engistan, in which there's a lot of deliberation. There's one Dr. Milind in Sangli, Miraj, that area, Maharashtra. He has been doing that for almost a decade. So, and he always used to actually, I always used to be a little skeptical about this, because why to underuse steroids, and steroids are the mainstay. And over a period of time, see, our surgical time is hardly 4 to 5 minutes, and in well-dilated pupils, we hardly touch the iris. And the patients post-op, and a lot of patients sometimes, for whatever reason, have not put steroids and they still come, they're doing fine. So we got this anecdotal evidence. At the same time, it was like a pilot. We started in some patients, and one of my other consultants, the other branch, Dr. Satyamurthy, started it. And after 6 months, there was a peer pressure. Even I started it. And now I find that if you select your patients, and most of the patient, topical phaco, short surgery, no iris handling, and I know that the patient will come back, local patients, you can definitely start this. It is a great enhancement of quality of life, because all these geriatric population have problems at home, their motor skills or social help is definitely less. They can't put hourly, 2 hourly, the way that we advise. And there's always a confusion. This is very easy. 4 times 1 week, 1 time 4 weeks is something rhythmic that they tend to follow. There is a sticker on the anywhere the eye bottle also. And this so far has worked well.
Because I had stopped steroids almost for 1 year, and what I have seen is wound scarring is more. I didn't give a steroid even for the first 1 week, and wound scarring is slightly more, and the beauty of surgery is a little bit less. And another issue is immediate post-op rise in pressure. What do you think is when you put steroid, you expect IOP may go high. But what exactly happening is, because of uveitis, intraocular pressure is going up in the immediate post-op period. And are you stopping steroids for TRAB also?
No, no, no. I'm a glaucoma surgeon. TRABs, see, the whole rationale is different. Here it's basically for intraocular inflammation, which is basically triggered during your, basically for, from the iris touch, okay, the prostaglandin cascade has to be blocked. There, it is basically a fistula. We don't want fistula to heal. So obviously, more the merrier, and obviously at least we have a minimum of 4 weeks, which can be even can go up to 6 weeks. TRAB is totally a different ball game. These two cannot be compared at all.
Definitely healing is much better if you don't give steroids. Healing, actually, if you don't give steroids, 1 week post-op will be looking like 1 month post-op. But wound scarring is there.
No, but out of the selected people, did you do an audit of how many people come back with post-op uveitis which needs to be restarted?
So that is again I'm saying, this I started very gingerly, very reluctantly over a period of time with a lot of pilots choosing patients who would come back. And to my surprise, we didn't have any patient coming. See, normally after 1 week when you stop steroids suddenly, there should be a flare-up. Okay, the patient should come back with pain, redness, whatever, irritation or slightly blurry. It never happened. So it never happened. They never, came back like that. So maybe that we are overusing steroids. Maybe our surgical trauma is pretty less at this point of time. I'm talking in relation to the surgery that we do in most cases today, topical phaco. So maybe it's time to cut down the steroid usage. Because you are basically making the patient getting addicted to steroids. So if you use it for 2-3 weeks and stop, there's always a flare-up. And if you use very frequently, probably it is like you're creating the addiction and then weaning would be difficult.
Do you think that solution with dexamethasone is going to be more effective in that initial period compared to prednisolone, which is a suspension?
No, I think whether it is dexamethasone, betamethasone or prednisolone, the molecule really does not matter because it is not like a case of a uveitis that you want to bring down the inflammation so drastically. The amount of inflammation that we create in, I think you all know, you are a testimony, it's actually very, very less. So you don't really have to hammer it down with a very powerful steroid, especially like difluprednate or prednisolone, which is likely to have higher IOP rise and other complications. I think any steroid would be fine. I'm not really, even prednisolone is fine, but we use dexamethasone.
So Ramurthy sir wants to comment? When JK was here, JK Reddy was telling he uses only lotiprednol.
That's our routine also. We use lotiprednol 3 times a day for 6 weeks. But I've done something intermediate in the sense that we use dexamethasone, moxifloxacin combination 4 times a day for 2 weeks. And then NSAID twice a day for 6 weeks. The main idea is that to reduce the load of preservatives on the eye. And very often you have excellent surgery, everything seems well, the patient is having discomfort, irritation, etc. So when you do this and put lubricant drops non-preserved 6 times a day for almost 6 weeks, I find that the incidence of these patients combining with non-specific irritation, discomfort has significantly come down. Maybe he has carried the rationale a little more, but I would be a little wary of cutting down on the NSAIDs also to once a day and 1 week steroid. I think what we do is something in between. And that seems to work well in our hands.
Dealing with this post-op uveitis, even if I tell patients that you might get something post-op, they come as though something great has happened and then relatives are worried, eye is all red and all this. So occasionally also even if after 3 to 6 weeks of steroids, still it is difficult to handle patients. So
I think what KP's logic is that if you put more steroids, am I right KP? If you put more steroids and then wean it, the chance for iritis is more compared to if you use it for a shorter period of time. That is what he is trying to say.
The choice of the steroid is also extremely important. For example, lotiprednol 3 to 4 times a day, it's a low strength, low dose, less chance of raising pressure. Use it for 6 weeks. But if you're using for 2 weeks or 1 week, I think dexamethasone should be the choice. There's literary evidence to suggest that also.
In my experience, when you stop or reduce steroids, even the late post-op uveitis incidence is coming down. It is less. when you stop steroids, you get, otherwise you get rebound inflammation. That is very less with...
No, but rebound, if there is no inflammation which is being treated, as being said now, then why should it flare up even after giving long-term steroid? If there is no inflammation to be controlled with long-term, being with high-end steroids, if you give it 2 weeks or 6 weeks, what is there to flare up if you give it more? That is what you were telling, no?
No.
That's what you were telling. What is there?
See, it's an observation that people who have been like we were using earlier 6 weeks and all that. So we used to always have a patient after finishing the bottle would come up with flare. Now with after 1 week and they're stopping it, this is not there. And my concern was not the patient coming with flare. My concern was CME, because CME is extremely rare in our practice after using Naproxen, all these NSAIDs. So I was thinking, these patients, will they come on? So there is at least I have a 2 years experience that I have never had a CME which can be probably attributable to the under usage of any of these post-op medication. And also using something like 3 times for 6 weeks is a very blanket thing, because the amount of inflammation or the anti-inflammatory activity required is not uniform for 6 weeks. It is highest in the beginning, then it goes down. So basically using something like we used to use it 3 times, 4 times or 6 weeks is actually a kind of a punishment, because after 2, 3, 4, 5 weeks, you don't need, maybe 3 times also. It has to be tapered. So tapering is the way, and stopping it early is another way of doing it the same.
Thank you to all the speakers, and thanks to the audience.